Hello, friends, and welcome back to Dr. A. Sajad. And today we'll be talking about Impetigo. I'm trying to do a 30-day challenge where I'll be putting up a video of one nice guideline every day for the next 30 days and see if we can work around that and how do we go forwards from there. So, impetigo is basically a skin condition that you normally see in kids a lot more than you'd see in adults. We start off by the clinical features, and the clinical features are divided into bullous and non-bolus, and they're quite characteristic when we'd want to pick up impetigo. So the non-bolus one would present as golden lesions, golden crusting with redness, while the bolus one would present as a vesicle which leaves a red, an area of redness. And for both of these, the rashes would last around 2 weeks. So you'd have a child who may or may not have systemic signs of infection. So the mother would say that she's been having this itchy. It's quite itchy. The children tend to itch a lot. The mother would say that she's been having this itchy rash around the mouth and on their limbs. And when you have a look at the rash would have golden crusted lesions. You'd want to look for any infection other than the impetigo over there. Some bacterial infection would be a good thought to look into. Um, it lasts for about 2 to 3 weeks, and the diagnosis, which is the second bit, is clinical. It's purely clinical, and most of the times, even the mother, when she comes in, she knows the diagnosis herself because it's just so characteristic and so common. Third up, we'll be talking about the differential diagnosis that we've merely touched upon. So, a few things that we'd want to look into would be wanting to just rule out bacterial, superimposed bacterial infections onto that lesion, and we might be confused with viral or fungal lesions, which is a lot less likely but still common. And sometimes a differential would also be dermatitis that we might confuse with the impetigo. But it's very, the way it's so characteristic. I think if you have the eye to look for something golden around there, you'll very easily be able to pick it up. Next up is the treatment. This is the tricky bit, and this is possibly where most of your management will be focused. The treatment itself is pretty simple. We've got some general measures that we want to look into. So kids should not go to school. So no school till 48 hours after crusting of lesion. So you'd notice those golden crusts, and 48 hours after that lesion has crusted, that's when we'd want to think about school. If it's a food handler, you'd want them to let the employer know. Um, Other than that, you'd want to print off a leaflet from the NHS website for your patient. And if there's any baseline infection that the child might have, like eczema, that may have probed the infection, then you'd want to take good care of the eczema or the psoriasis in the background, as well as the impetigo. So those are the general measures. After that, we'll pick up on the specific treatment. The specific treatment, according to the NICE guidelines, is hydrogen peroxide, but that's just to consider. hydrogen peroxide, but the real treatment that you would practically put a lot to use would be fusidic acid. And if you don't want to use acid, then we've got the mipiricin acid as the second line. In patients that might have extensive or recurrent impetigo, then we might want to consider oral flucloxacillin. And according to the NICE guidelines, you wouldn't want to give them together. So you'd want to choose whether you want to give the oral or the topical treatment. And ideally, it would be for 5 days. But if it's very extensive, that's when we'd want to think about it about 7 days. And according to the NICE guidelines, if you see those vesicles and it is a bullous presentation, you can very well just jump off to the oral fluclox rather than sticking to the topical and then stepping up to the oral flucloxacillin. So that's the treatment itself. Sorry. There are chances you might have to refer to dermatology if the infection is very recurrent or it's very widespread or it's complicated. And sometimes, if the diagnosis is unclear and you're confused along the lines of dermatitis, there could be cases where the child is very, very septic with the disease itself, and you might need to send the patient to secondary care. And if you notice that there are lots of kids or from one nursery or lots of adults from one care home, then we'd want to let the communicable diseases be aware of the situation as well. Last but not the least, the NICE guidelines talk about the follow up for this disease, and the follow up is pretty simple. If the patient was on topical flucloxacillin, sorry, I've picked up the same color somehow. Let's go back to that calm blue that we were using. So if we had started the patient on topical hydrogen peroxide, it didn't work, we switch it up to topical flucloxacillin. If topical flucloxacillin doesn't help, we step up the treatment to oral flucloxacillin. And if the patient is allergic, we might want to think around the lines of clarithromycin and erythromycin. And the second thing that we want to think about on follow up, which is very, very important, is if we're giving the treatment and it's not getting better, then we'd want to look into swabs. And swabs are very, very important because we might think we're right, and we might think that we've got the diagnosis, but sometimes swabs can help you come down a lot to a solution quite quicker and quite better. So sending out swabs on a follow-up would be a good decision, just to rectify, just to make sure that we've got the right diagnosis and the right treatment and plan. And then we can step up the antibiotics by the sensitivities on the swabs itself. So this was a pretty easy one. It's Impetigo, and we've done it quite quickly with the clinical features: golden crusting lesion, sometimes a vesicle. Both of them, when the lesion starts to dry off, it leaves off an area of redness. Last, it's quite itchy, and it lasts for about 2 weeks. The diagnosis itself is clinical. You can add a swab if you're uncertain. The differential diagnosis would be a superimposed bacterial infection, or if we're just skipping or missing the rash itself, is it a bacterial rash, a viral rash, a fungal rash, or a dermatitis? Treatment: general measures: no school till 48 hours of the crusting of the lesion. If the patient is a food handler, they might want to let their employer know, and to just give patients leaflets and lots of information about it. Specific treatment: to consider hydrogen peroxide, but clinically, topical fusidic acid is the treatment for 5 days to go to. And if it's extensive, if it's recurrent, if it feels a bit complicated, then oral flucloxacillin for 5 days. If it's not getting better on follow up, to send out a swab and to treat accordingly. So that's my take on the impetigo. We're going to do we're somehow going to try one video a day for the next 30 days and just see how that propagates the channel itself. So thank you for watching. This is Dr. A Sajid. Please do let me know in the comments if there are any particular topics that you think we should cover together. I'd love to do so. All right then, bye.